Hi, my name is Danielle Anderson, and I'm the Wellness Specialist for the Deer Valley Unified School District. This webinar-style presentation is designed to help parents, staff, and students identify disordered eating behaviors and patterns. Many of us understand just how important proper nutrition is for the growth and development of children. Their overall health, both their bodies and minds, truly depend on it. And when it comes to eating disorders, prevention and early intervention working together provides the best possible outcomes. We'll begin this presentation by looking at a few eating disorder statistics. Although the peak age of onset occurs primarily between ages 10 and 19, research does indicate that children as young as 9 demonstrate disordered eating behaviors. And the chances of school staff encountering students with disordered eating is very likely. Unfortunately, many with eating disorders do not actually seek treatment. More than 50% of adolescents and young adults endorse dieting, and with a large portion of our society encouraging dieting behaviors, they often segue into disordered eating or are intertwined with eating disordered behaviors. Those who engage in dieting and disordered eating behaviors are at an increased risk for more severe forms of dieting and disordered eating later. Number 5, childhood into adolescence is a major developmental period for eating behaviors, and this is an opportunity for both good and bad behaviors to develop. And number 6, eating disorders do occur in both genders, although predominantly occurs in females. Males, especially those with depression, also deal with eating disorders. And lastly, eating disorders have the highest mortality rate of any other mental health illness. And so in the following 2 slides, we will discuss common eating disorders and their often seen symptoms. On the first slide, you see restrictive behaviors as well as binge eating. With restrictive behaviors, there's a lot of rules about eating. There's little variety in the foods consumed. There's an avoidance of social eating, and you're generally cutting back on the amount of food consumed. Basically, an incessant calorie counting and or knowledge of what each food may contain calorically, nutritionally, the ingredients that are in each food is something that dominates the focus. In terms of binge eating, it is more about a lack of control around eating. So that could mean both restriction and binge eating. It's where the body becomes essentially insensitive or unable to recognize hunger and satiety cues. It's a lot of eating without hunger. It's eating until discomfort. It's eating alone due to embarrassment. And it's often related to emotional eating and then feeling upset about the eating behaviors, guilt, disgust, depression. And so continuing on with common eating disorder symptoms, we see purge behaviors. Purge behaviors are those behaviors where the individual is trying to compensate for the food consumed. And so you have self-induced vomiting, spitting, using laxatives, diuretics, and diet pills inappropriately. And then there's also compulsive, intensive exercise. Exercise is actually an extremely common compensatory behavior with disordered eating. And so it's something to keep an eye out for. You can listen for language like, I can eat that now because I did this exercise, or because I ate blank, I now have to spend 3 hours on the treadmill. Along with purge behaviors, you have body monitoring and body avoidance. Body monitoring can be a demonstration of both shame and pride. There is a constant focus on the body. That's probably the most important feature. And so you have repeated weighing, measuring of the body, pinching skin and fat, checking for bones, and just basically looking at themselves a lot, as well as comparing themselves to others. Body avoidance is also a common feature when an individual only sees negative in their body, and thus they try to hide their appearance as much as possible. And they might do this with big baggy clothing or just in general being a little bit antisocial. As mentioned earlier, early detection and early intervention of these behaviors are critical. Once eating disorders gain strength, the behaviors are very hard to change. And unfortunately, because the growth and development that takes place during adolescence is so significant, serious medical complications can develop. Long-term issues such as dental issues, growth retardation, decline in cognitive abilities and memory, osteoporosis, and infertility can result. And also, because children have less nutritional reserve than adults, it can cause an increased risk for medical complications to escalate quickly. There's not a lot of padding in children, so to speak. So the sooner the better. So early detection and early intervention is key. And so why do eating disorders develop? There are so many variables that have the potential to increase the risk of disordered eating development and continue extreme dieting and weight control practices. The next two slides will look at personal, socio-environmental, and familial risk factors. First, the personal risk factors. Low self-esteem, depressive systems, body dissatisfaction, where there is a continual negative comparison between the self and others. Weight concerns, where there is a value on thinness and a stigma of fatness. And then there's the physical and emotional changes that are due to puberty and pre-puberty. There's a ton of emotional and physical changes that occur during this time, added stress that children are often not equipped to deal with. And without proper coping mechanisms, food regulation and/or addiction becomes a way to deal with the situations at hand. Socio-environmental risk factors are those that are occurring around the individual. So maybe they don't have any social support. Perhaps there is certain dieting norms within the peers, and this can happen a lot with certain athletic sports. Also weight teasing, and weight teasing comes in many different looks. There's the criticism, there's bullying about what the person looks like, bullying about their food choices, body shape in general, if it looks anywhere different from the norm that has been established. And then this weight teasing can come from both peers and family. Familial risk factors can be significant as well. If there's discord or dysfunction, or there's a lacking communication or support in general, those are times where the individual might seek help elsewhere. Also, parental relationships with food and dieting. So the parents' own weight concerns. Are they constantly dieting? Are they establishing that behavior as the norm? Do the parents' own weight talk and views of weight dominate day-to-day conversation? So research does indicate that there are no instances where family weight talk, constant discussion and acknowledgement, and dieting are associated with better outcomes for the child. A lot of times it ends up turning into what appears to be a kindly shape teasing, and in fact that's not typically beneficial. And so in summary, here are some of the most common predictors of eating disorder development. Number one, research indicates that early formation of dieting and disordered eating behaviors often will set the stage for continued reliance of such methods and then eventual relapse. Number two, reliance on weight control behaviors is one of the most consistent predictors for eating disorder development, and it is simultaneously found to be counterproductive to weight management in general. Number three, early on body dissatisfaction, dieting, and weight-related teasing are prominent predictors. Number four, weight culture and acceptance of weight. And then number five, the family culture and norms around food. How can we help adolescents build healthy relationships with their body? We should first stress how dieting and disordered eating behaviors are counterproductive to weight management. They don't help in the long run. They're not sustainable. Willpower only lasts so long. We need to steer children away from unhealthy weight control practices, food restriction, binging, purging, body focus, body comparison. These are not healthy behaviors. Number three, encouraging children to engage in healthy lifestyle changes, such as incorporating balanced meals into their day-to-day, eating regularly from all food groups, listening to hunger and satiety cues, and participating in daily physical movement. We also should be explaining how dieting often predicts future weight gain, overweight status, disordered eating, and eating disorder development. And so then we need to avoid reinforcing these quick weight losses or fixes, and we need to avoid stressing importance of a particular body size. Lastly, talk only goes so far. Students learn from the examples around them. So how can we be most effective? Research suggests that schools maintain an open dialogue about mental health. This helps attend to students' needs quicker. Also, it is clear that many eating disorder behaviors are not food-driven, although that is how they are most often viewed. Disordered eating instead becomes how individuals deal with their difficulties, which in turn only makes things more complicated. As school staff and family, you aren't expected to have all the answers. It's more about guidance, helping to guide healthy eating and physical activity, and helping to intervene if you observe a student struggling. Counselors, nurses, and teachers, we all have an opportunity to spot potential risky behaviors because when these behaviors are not treated, they will most likely worsen with time and age. We do have an RD on staff, a registered dietitian, and if you think a student is having a difficult time, please contact the Food and Nutrition Department of DVUSD. Thank you for your time. My name is Danielle Anderson, and I am the Wellness Specialist for Deer Valley. And here are all of the references that were used within this webinar. Thank you.